Hi, I'm Dr. Donald Jurovich, and today we have a presentation on sleep disorders as part of our Dakota Geriatrics program, which is a program funded by the federal agency HRSA, and its program called the Geriatric Workforce Enhancement Program. So today's presentation is on sleep disorders in older adults. We want to firstly do a case study here. So 80-year-old female with she has 6 months of difficulty staying asleep. She frequently naps during the day, and it turns out that her nighttime awakenings disrupts her husband's sleep as well as her overall quality of life. So the individual falls asleep easily early evening and then wakes up about 2 hours later. During this time, she may go to the bathroom, she may putter around for a few hours, and she goes back and forth like this until her usual wake time of 6 a.m. So she, a sleep diary or information from the patient and the spouse indicates that she has at least 3 awakenings during the night. She sleeps after breakfast for a couple of hours and takes a nap or so in the afternoon, and she's irritable more in the evening, and importantly, she has moderate Alzheimer's disease. So here's a question for you. Which of the following is the best treatment approach for this person's sleep disorder? Prescribe melatonin, trazodone, or refer to cognitive behavioral therapy, or provide bright light exposure during the day. So go ahead and take your best selection. And the correct answer for this is bright light exposure during the day. So basically 2 hours of bright light therapy, 10,000 lumens would be the appropriate choice for this individual who has difficulty maintaining sleep at night. And it turns out that bright light therapy works both for the cognitively intact and for the cognitively impaired older adult. So important information there. Just turning to the objectives for this presentation, we want to look at the physiology of sleep change in the older adult, and then move to common psychiatric, medical, neurologic issues related to sleep perturbations, talk about the different methods for sleep evaluation and what interventions we recommend. So in terms of the topics, we're going to cover the epidemiology of insomnia in older adults, and we want to look at the evaluation of sleep issues, focus in on some specific issues related to dementia and sleep, and also how these sleep issues are different in the both acute and long-term care setting. So we know that sleep hygiene with aging is disrupted because of multiple chronic conditions. So we've mentioned previously that older adults break up into one of 3 groups. Either they have 0 or 1 chronic condition, another third has 2 to 4 chronic conditions, and then another third has 5 or more chronic conditions. As those chronic conditions increase, there's increasing incidence of pain. A lot of this can be associated with nocturia, particularly if somebody's on diuretics or has some form of diastolic or systolic heart failure. Compounding sleep hygiene are mood and cognitive disturbances, as well as the epidemic of sedentariness amongst older adults. We also know that there are recurrent sleep disorders in the older adult population, including obstructive sleep apnea, incidence of restless leg syndrome, and circadian rhythm disorders that we need to consider. So it turns out that women have more sleep disorders than men. African Americans have more sleep disorders than white elderly, and overall there's about a 30% incidence of insomnia with the older adult population. As a consequence of that, 5% of older adults use some form of sleeping medications. There is an increased risk of death in the nursing home setting, or also with nursing home placement, I should say, with individuals that have persistent insomnia. And the subjective elements of sleep problems is linked to a poor quality of life. And importantly, sleep disruption can be an indicator of early cognitive decline. So here I want to show how melatonin spikes during night are altered during the aging process. So it's pretty evident here that the peak levels decline in older adult populations, as evidenced here in these 82 to 86-year-olds. There's other circadian rhythm disruptions. So you can see that temperature changes here. The red represents older adults, that you have lower temperature fluctuations. You have different levels of peaking and nadir cortisol levels. We already talked about the loss of melatonin, cyclic rhythm, as well as the absolute amount, and then some subtle changes in the 24-hour glucose levels. So we know that the sleep characteristics do change with age. A lot of times there's a decrease in total sleep time. Sleep efficiency is less. There might be increased daytime napping, and that there's lower REM sleep. So again, the quality of the sleep decreases with increasing age. So in the clinical workup, I think it's important just to ask some questions. So the first one is, how is your sleep? And then if you do have sleep issues, do they interfere with your daytime activities? And then you can also ask an informant, so a spouse or a family member, if the older adult, your patient, has any issues with snoring, or if they've recognized nighttime sleep apnea or leg movements. In order to do a initial evaluation of sleep problems, it's good to use standardized sleep questionnaires. Certainly you can do a sleep log, much like we got information from our case study where the husband indicated that there were at least 3 instances per night where the individual got up for about 30 minutes and then went back to bed. You can also use actigraphy. So for those that have Apple Watches or other devices, you can actually track your sleep based upon movement. And then you also want to consider memory and depression screens, again, because cognitive impairment and depression can be associated with sleep disruption. So this is a prototypical polysomnography. It's best used for situations where you have sleep apnea, narcolepsy. I've actually been involved in some medical review of legal cases where an individual who's elderly fell asleep at the wheel while driving and ran into a group of motorcycle individuals across the other side of the road, killing one of them. And it was later found out that this individual had narcolepsy that was undiagnosed by the primary care provider. Also, polysomnography is important for periodic limb movement. And importantly, I want to point this out, that you don't need polysomnography for restless leg syndrome. So for those that are interested in internal medicine or geriatric boards, this might be an important question that may come up. So the DMS-5 category of insomnia disorder is defined here as difficulty in initiating or maintaining sleep. So are they having problems getting to sleep, or if they are okay with getting to sleep, do they have problems maintaining that sleep? So that is associated generally with waking up a little too early, and it can be different periods of the night when they wake up. It could be like a couple hours after going to sleep, or it could be 4 to 6 hours. And then it's also often associated with daytime impairments, which include fatigue, poor concentration, sometimes forgetfulness, daytime sleepiness, and then overall anxiety and concerns about sleep. In terms of insomnia, it's often linked to depression and anxiety. And untreated sleep disorders themselves will reduce your ability to perhaps pharmacologically manage depression. And it's important to point out that caregivers have sleep difficulties, and we'll talk about that a little bit later on in this presentation. But insomnia is also closely associated with an increased risk of suicide. So that's another important correlation. Insomnia can be associated with multiple chronic conditions that we can see here. Probably the biggest issues that I see in clinical practice are those related to gastro reflux disease, that burning sensation and reflux disrupts sleep. Pain is also a big component, as well as Parkinson's disease or Parkinson's syndrome. So medications that can basically exacerbate or cause sleep issues are, as you might imagine, diuretics, particularly if you take the diuretics if the instruction is to take them at bedtime as opposed to at 4 p.m. You're going to have the effect of the diuretic in the middle of the night and causing people to urinate frequently. Remember, stimulants can disrupt sleep, and caffeine is basically a 24-hour drug. So drinking caffeine in the afternoon, it carries over into the next day, noon the next day. So you can imagine how all that might impact your sleep. Bronchodilators, so the adrenergic system stimulation can cause sleep disruptions, and then also the adrenergic system being stimulated by antidepressants that are of the SNRI class. So those serotonin uptake and norepinephrine reuptake inhibitors can cause a real activating syndrome there. You can also get nightmares from cholinesterase inhibitors. So those would be the Ariceps and the rivastigmines. Parkinson's medications, all of them can be associated with nightmares, as well as the lipophilic propranolol. Medications that are associated with insomnia, chronic use of sleepers, sedative hypnotics, really disrupt the sleep quality, and they might lead to some form of tolerance. And if you stop them suddenly, they will cause rebound insomnia. So that's an important consideration, is that, as you titrate up on some of these medications, you need to titrate down incrementally. Probably the biggest problem I'm seeing there is that fourth point is alcohol use. I don't know if I want to say abuse, because it turns out that anything more than one drink per day can be associated with sleep disruption. So the combination of sedatives and alcohol can also compound sleep apnea, and so that's important, particularly in the individuals that have BMIs of 30 or greater. So that's always a word of caution. So let's talk about central sleep apnea. It's a central nervous system or a cardiac dysfunction that impairs respiration. So the question is it a result of disease, or is it a central nervous system disorder? Oftentimes we just don't know. So treating the underlying disorder really becomes important, such as good control of congestive heart failure, either systolic, diastolic, or both. In terms of obstructive sleep apnea, we know this to be a airway obstruction. Often it's reported as daytime sleepiness. Sometimes you wake up in the morning with a headache. The individual might complain of memory problems. Their personality may change. And importantly, in the clinic setting, if you see somebody with poorly controlled hypertension, let's say you've gone to a third antihypertensive and their blood pressure still is not well controlled, this would be something to consider as an etiology, obstructive sleep apnea. So obstructive sleep apnea is often associated with high BMI. And then again, just emphasizing that if resistant hypertension might prompt your thinking about OSA. And alcohol intake is an important risk factor. And obstructive sleep apnea can lead to dementing illness. It is also associated with cardiovascular disease. I mentioned about the motor vehicle accidents and narcolepsy, although there are two different conditions, but nonetheless, the daytime somnolence that's induced by sleep apnea can lead to accidents. We already talked that it might be associated with cognitive impairment, and it increases all-cause mortality. Now that contrasts with periodic limb movement during sleep. This is a stereotypic repetitive movements. It occurs during non-REM sleep, and it can only be diagnosed definitively with polysomnography. Now that contrasts with restless leg syndrome, which is considered a unpleasant feeling in your legs. A lot of times people call them cramps or a burning sensation. And it's just, you got to get up, got to get out of bed and walk it off. So this occurs in a fair portion of the population, and it does not require polysomnography to make the diagnosis. Some of the medications that can aggravate restless leg syndrome is our bad boy called diphenhydramine. Okay, so this is highly anticholinergic. It's unfortunately used frequently in the hospital setting as a sleeper, and it's really causes high cholinergic burden, and it's to be avoided at all costs if possible. Tricyclic antidepressants are also, all the antidepressants may aggravate restless leg syndrome, as do the antipsychotics. So one of the key things to think about in restless leg syndrome is to evaluate the ferritin, and restless leg is associated with low iron stores in the brain. So you might actually have a normal ferritin level in the blood, but studies have shown that there might be low brain levels. And this just kind of reinforces that. So there was a study that looked at cerebral spinal fluid ferritin levels in restless leg syndrome. And I just want to bring your attention to the fact here to the right that, firstly on the left here, the serum levels here in the middle are equivalent for ferritin, this middle graph. And then you can see the middle graph here on the right side that the spinal fluid levels are half of that of the, and actually less than the normal individuals without restless leg syndrome. So again, it just demonstrates that just because you have a normal serum ferritin level, you may have abnormal iron stores, which actually is an aging phenomenon. There's a certain percentage of the population that redistributes its iron into the reticuloendothelial system and then pulls it out of other tissue. So that may be one of the explanations for what we see in restless leg syndrome. So the treatment recommendations are to provide intravenous iron therapy for restless leg syndrome. The quick fix is to give a 1,000 milligram infusion as opposed to that 200 milligrams over 3 to 4 doses spaced by 2 weeks apart. Other non-pharmacologic treatments of restless leg include yoga, and exercise. So that's the non-pharmacologic interventions. In terms of the pharmacologic interventions, if your iron therapy doesn't work, you can use medications like ropinirole and pramipexole. There's equivocal evidence as to whether gabapentin works, but that might be another treatment choice. The real problem with these, the Requips and the Maripexes, is that in older adults they cause retrograde amnesia. So they'll take those medications and they'll just forget periods of time. So that's the wrap on those medications and why they should preferentially be avoided in the older adult population. There's some emerging evidence that high-dose vitamin D levels may actually improve restless leg syndrome. So trying to target 50 nanomoles would be another option. The circadian rhythm sleep disorders are also common with aging. Typically, these are individuals that fall asleep and then awaken early, versus the other version, which is fall asleep and awaken late. So those are the two considerations. It might be common in pre-dementia syndrome, so that's why I was saying that some of these sleep disorders might be a harborer of dementing illnesses, and you might want to do a little deeper dive in terms of evaluating their cognitive status. So you can diagnose circadian sleep disorders through either sleep logs or actigraphy. Light therapy is the preferred intervention. So if the problem is getting to sleep at night, you want to prescribe 30 minutes of 10,000 lumens of light. And again, the light boxes can be at the side. You don't have to be staring right at the light box. They just should be on the side, but close enough to your vision to provide retinal exposure. Then conversely, if somebody has problems maintaining sleep, then that is 2 hours of light therapy early evening, basically. You can also add low-dose melatonin. So you start off low and let the patient know that's not going to work immediately, because everybody says, well, I took this, Xanax or something and put me to sleep right away. Melatonin won't do that. It's going to take several days to weeks to kick in. And then if it doesn't work at the lower dose, then you gradually escalate it. You can use melatonin receptor agonists, particularly if there's low vision or blindness in the older adults. So that's an FDA-approved intervention. In terms of REM sleep behavioral disorders, this is associated with excessive motor activity at night. I've got a little photograph here by Henry Fuseli that talks about the demons in your nightmares. This is often associated, this condition associated with Parkinson's and Lewy body dementia. And these are the individuals that come into clinic whose wife has a black eye from being hit in the middle of the night, unbeknownst to the patient, or that they get leg injuries and so forth. So this is required to have polysomnography to make the diagnosis. So for the REM sleep behavior, the treatment is melatonin. In either Parkinson's disease, I'm showing Muhammad Ali and his what we call punch drunk or pugilistica Parkinsonianism. The other treatment for these REM sleep behavioral disorders could be clonazepam, but those are to be avoided in the older adult, just simply because they have such a huge risk for falls and, like I say, amnesia. I want to turn a little bit towards cognitive disorders such as dementia and sleep issues. So demented older patients have more sleep disruption. They get up in the middle of the night more frequently. It's poor sleep efficiency. It's not as deep sleep, and it's overall just fragmented sleep. A lot of times they'll have that reversal of the wake-sleep cycle, so they're up at night and they're sleeping during the day. So some of the interventions for sleep disorders and dementia, you might want to avoid the cholinesterase inhibitors such as Aricept and rivastigmine because they may get vivid dreams and worsen their insomnia. We actually had a patient come in from assisted living with exactly that issue. She had just been started on a cholinesterase inhibitor for her moderate dementia, and so we discontinued that. The issue with sedative hypnotics is that they will increase falls and they don't impact REM sleep, so those are to be avoided as much as possible. And you might empirically evaluate for obstructive sleep apnea. The important point is that demented patients, certainly those that are moderate to mildly impaired, can indeed comply with CPAP therapy. And then finally, we would recommend bright light therapy depending upon what the sleep disorder is. If it's problems getting to sleep, it's bright light in the morning. If it's problems maintaining sleep later in the night, then it's bright light therapy in the mid-afternoon. Well, I don't want to go bit by bit here, but just suffice it to say that there are both negative outcomes of sleep efficiency using melatonin, as well as data that shows that it does work. There's these so-called sedative antidepressants such as mirtazapine and trazodone, and typically their sleep efficacy is at the lower doses, and so mirtazapine typically should be more towards the 7.5 dose, the trazodone closer to the 25 milligram dose, but some randomized controlled trials show neither of them are very effective as sleep agents. The only one that kind of intrigued me was this one at the bottom here, where memantine in Alzheimer's disease improved sleep quality. So just to reemphasize in terms of dementia, consider non-pharmacologic interventions. We talked about light therapy. So there's actually one study that showed rather than 30 minutes, they did 60 minutes of light therapy in the morning, and that improved their sleep. Dance movements with familiar music is also a therapeutic approach. In one European study, they did home visits and talked about sleep hygiene with those home visits. Increasing physical activity, particularly before dinner time, is going to improve sleep hygiene. And then in terms of pharmacologic management, I mentioned the memantine story, as well as melatonin as potential trials, as well as the other consideration of discontinuing the acetylcholinesterase inhibitor. If you're looking at sleep issues, also address the caregivers for the older adult. They do lose a lot of sleep, and again, they have similar problems with sleep hygiene. It is exacerbated by depression, and it can really lead to caregiver burnout. Well, this is kind of a little bit of a sidebar here. So as I was looking at whether heat therapy in a hot bath improves sleep, and there is some evidence that it does do that, I found this really fascinating study of a regular Finnish saunas in several thousand Finnish men. So basically using one sauna per day versus 5 saunas per week, so the range was from 4 to 7 saunas per week, and you can see the hazard ratio declines to under 0.4 for frequent sauna use. So if that doesn't give you an incentive for getting a sauna in your basement or elsewhere, I don't know what else will incentivize you. I want to talk about the hospital-based sleep disruption. Certainly the loudness of the environment contributes to that. People are waking the patient up at all hours, either for medications or for vital signs. So noisy, you're bed bound, it's encouraged that you stay in bed as opposed to getting up and around. and there might be new medications that are going to disrupt your sleep. Tethers, whether they be IV or urinary catheters, can also be a problem for sleep disruption. The approach is somewhat similar with some other considerations for dealing with the older adult with generalized sleep disorders or biorhythm, circadian rhythm disorders. So applying bright light. I don't know if you've prescribed bright light before, but it is something that can be considered in the hospital setting. Changing the morning medicines to a later time period as opposed to 6 o'clock in the morning, which may not coincide with the person's usual circadian rhythm. I want to point out to try and avoid diphenhydramine because that leads to an increased risk of delirium, particularly if there's other anticholinergic medications on board. You can also prescribe melatonin, again with the caveat that it's not going to work immediately. It's something that may take a couple of days to kick in, if not weeks. The point here is, as part of the Choose Wisely campaign from the American College of Physicians, is to avoid sedatives as a first line of therapy. You might consider nighttime use of Tylenol and also other non-pharmacologic therapies such as topical Voltaren or other liniments, ointments, lidocaine patches that might address nighttime pain. And then keep an eye on the patient. Let the nursing staff know, as well as others, to try and keep the older adult up during the daytime and encouraging physical activity as best they can. And simply just sitting in a chair and doing arm cranks in ergometry is beneficial. And then for chronic symptoms for insomnia, that typically needs to be referred to a psychologist for cognitive behavioral therapy, where they go through an actual sleep deprivation schedule to get the person's sleep pattern back on the tracks. So to encourage sleep hygiene, these are some of the things that you might put in your electronic medical record smart phase or handouts, brochures, whatever, to encourage the older adult to maintain a regular rising time, to use bright light therapy according to their symptoms, avoid napping, exercise, and to do so before dinner. Also to discourage reading or TV in the bed. The bed should be for sleep only. To also prep yourself 30 minutes for bed with mental relaxation, whether that be meditation or reading a non-tablet, like a regular book, would be useful. And then also applying white noise at the bedside. A big one is eliminating or at least reducing alcohol. See about caffeine. A lot of times people don't always think about their Coca-Cola as being caffeinated. And certainly nicotine use, whether it's chewing tobacco or smoke, all can be stimulants that disrupt sleep hygiene. Again, trying to prep before bedtime, about a 30-minute wind down of some sort. You can also consider environmental elements that such as earplugs or eye shades. Certainly here in North Dakota, for example, during the summer when it stays light up until 11 p.m., 12 p.m. at night, getting eye shades may not be such a bad idea. Also consider body comfort, so warm feet might be just simply putting on a good pair of woolen socks to help keep the feet warm as a sleep hygiene intervention. Importantly, if you can't get to sleep within 30 minutes, the recommendation is to get up and get to another room. Don't stay in the bedroom. Either do some meditation or do some short reading, and then try to readdress your sleep with all the other elements that we recommended here just a short time ago. Some of the non-pharmacologic interventions for sleep hygiene basically are listed here. The points that I want to make is the idea of reconditioning. Some of these are, again, through the bottom here of cognitive behavioral therapy to reset the sleep cycle. But I think the most important prescription that we can do is to offer light therapy here at the bottom, the 10,000 lumens. There's actually a technique where you tense and relax each muscle group. So you start from your toes to your feet to your calves. So you tense them up and then relax them, going all the way up to your jaws and temporal masseters and neck muscles, for example. So that's a technique that you might instruct your patient to do as part of a relaxation routine as they go to bed. So these are just some of the examples here of what to expect. So the stimulus control, where the patient is instructed to go to bed when they're sleepy, and to basically use the bed for sleeping and not for other activities. Also to try and avoid nighttime snacks shortly before sleeping. The sleep restriction is a opportunity to offset the sleep, so you shorten the sleep stay, and then you increase it by 15-minute increments. The cognitive interventions, basically these include things like imagery, education about some false beliefs about sleep, and it's important that with these individuals, you have to be mindful of them being cognitively intact, because the demented patient does not really respond to rationalization or argumentative type discourse. So always remember that in the cognitively impaired individual, older adult, you always go with the flow. You don't challenge them. So those cognitive interventions aren't going to work so well in the demented patient. We talked about relaxation techniques, so whether it be a massage, vibration, a warm bath, hot shower, for example, and then also mental imagery, or just meditation, focusing on your breathing alone. These are all relaxation techniques that we're familiar with. So try to avoid the sleepers, all sedatives, as well as SSRIs, the sedating SSRIs, all the antidepressant medication class increase the fall risk by 1.6 to over 2 odds ratio considerations. So these sleepers also contribute to amnesia, and long-term use may lead to dementia. Be careful with them, because they can be associated with rebound and withdrawal syndromes, and there's a lot of somnolence and daytime carryover, because some of the even short-acting are not as short-acting as we may think. So these are the different medications that you can consider. Again, the trade versus the generic name. You can see the starting dose for those and some of the side effects. So it turns out that there was a study done on zolpidem that within 30 minutes of taking the medication, the older adults that were studied had a postural instability that was about the equivalent of a drunken sailor. It really was quite impressive that no sooner did they take the medication than they had a tremendous gait disturbance and postural imbalance that was made worse by perturbation. So the melatonin receptor agonists are listed there with some of the side effects over on the right-hand column there. And melatonin is basically the preferred intervention. And Servoxurant is another medication that can be considered. I don't have a lot of clinical experience with this, and again, it has considerable side effects and carryover effects into the day that might affect driving. The low dose SSRIs are listed here. Again, just the point of view that they can be associated with fall risk and next day driving impairment. So if you have individuals that are on chronic benzodiazepines, that increases overall their morbidity and mortality, and overall it will get short-term benefits, but it'll exacerbate sleep problems over the long run. And it's really hard to convince people of that. They really do have a true dependency for some of these individuals that have been taking these benzos for many, many years. To deprescribe, it's important to do low and slow. So you use half the dose every 2 weeks, or even a slower taper. Sometimes I've used every month to try and decrease the amount of medication that they're taking. Just words of caution. I mentioned Tylenol at bedtime for pain control, but avoid Tylenol PM. Why? Well, because it's the second line there. It contains diphenhydramine or Benadryl. Try to get people to reduce their alcohol intake, and just point out that some of these over-the-counters such as valerian and kava really are not effective as sleep aids. So just to summarize, you can use polysomnography for individuals that are not responsive to your sleep intervention as to however you diagnosed it, just with the caveat that you don't use polysomnography for restless leg syndrome. And I just reemphasize that because I've seen that on the boards previously. Non-pharmacologic interventions for both insomnia and restless leg syndrome include bright light therapy, melatonin, and all those factors we talked about with sleep hygiene. And this is just to summarize some of the references that we have, that I cited in the presentation. So I appreciate your attention, and I hope you've learned a little bit more about how to evaluate and treat sleep disorders in the older adult population. Thank you for your attention.